So thank you. My name's Charlotte. I'm a haematologist. I work at the Royal Marsden Hospital in London, and I run a research lab at the Institute of Cancer Research next door. And I think this was quite a daunting task to try and think about all of the side effects of myeloma treatment and talk about how we try to think about managing them. And that's because when I put together the outline of my talk, I'm afraid it looks a little bit like this, which is kind of a long list of every possible part of the body that any treatment that we have to treat myeloma could possibly affect. And I'm conscious when we talk about side effects with patients, we're often also giving really long lists of things that could potentially happen. So I think it's important to remember as I go through this that not everybody will experience every side effect. What I'm talking about is the possible side effects, and hopefully they're obviously all related to different drugs, but I've chosen to do it in this way rather than tell you all the side effects of each common drug, just to try and focus a little bit on why things are causing side effects and what we can do to help minimize them. So hopefully that's not too daunting a list to get through, and we'll make a start and launch right into the first one. So I was going to start with thinking about hematological side effects, because I think it's important to know what that word means, because we kind of bandy it around a lot as hematologists. And really we just mean any side effect that affects any of the blood cells that are made in the bone marrow. So this is my diagram of the bone marrow, and in your bone marrow you're making normally red blood cells that help you to carry oxygen, white blood cells that help to fight infection, and platelet cells which help the blood to clot. And in myeloma, obviously the myeloma itself will impact the generation of all of these cells, because the myeloma is taking up space in this bone marrow where it shouldn't be and where the normal blood cells should be being made. And so myeloma itself will impact the generation of all of these cells. And then on top of that, the treatments that we give can also impact these cells. And that's because myeloma cells are derived from a white blood cell, a normal plasma cell that is also generated and hangs out in the bone marrow. And so if we're trying to target that type of cell with our myeloma treatment, we're inevitably going to have a little bit of an effect on some of the other cells that are made in a similar way and perhaps have some of the similar characteristics. So it's important, I think, when we think about this, that it's both the myeloma and the treatment that we're giving. And we have some good ways to try and help with some of these problems. So we have ways of, I've called them replacement cells. So if you are not making enough cells in our bone marrow, then we can have red cells or platelets transfused from donors in the form of a blood transfusion or a platelet transfusion. That's not so easy for the white blood cells. You can't deliver those in quite the same way, or at least safely. And so we have what we call, or what I've called here, boost therapies for those cell types. So we can use a hormone called GCSF to boost the white cells called neutrophils, and we can use a hormone called erythropoietin to produce more production of red blood cells. So alongside perhaps, or instead of having a packed red cell transfusion, you can use erythropoietin to boost the red cells. But this is a way of replacing those three main cell types. So these are things that we can replace. And I guess the most common time when we need to do this, or the treatment that has the biggest impact on all of these blood cells, are the autologous stem cell transplant process. So I've just got here some very brief slides just to make sure everybody's on board with what I mean when I say that. So an autologous stem cell transplant is a treatment we use usually in younger, fitter patients with myeloma. And this is a way of delivering a particular kind of chemotherapy called melphalan chemotherapy. But in order to do that safely, we have to first harvest stem cells from a patient. So we give some treatments, that GCSF that boosts the white blood cells. We give that treatment to release the blood stem cells from the bone marrow into the bloodstream, so that we can then collect the blood stem cells and we can freeze them until we need them. And then at a later date, carry out the transplant procedure, which means basically administering chemotherapy that's aiming to target any leftover myeloma cells that might be still there after initial induction treatment with this chemotherapy called melphalan. And then the following day, we return the thawed blood stem cells, having taken them out of the freezer, to try and help repopulate that bone marrow and get the normal cells being made again. And we also provide other supportive treatments until the immune system recovers during that time. But this is a point where we're kind of often needing to use some of those replacement cell therapies or the cell boost therapies. I thought we would divert here and just think a little bit about the other side effects of autologous stem cell transplantation, because they will come up again, some of these side effects a bit later, but just to highlight in the short term during the transplant procedure, the most commonly experienced side effects are feeling sick or being sick and having diarrhea. We're particularly concerned about the risk of infections during this time. That's why often patients are kept in hospital or maybe at home, but safely away from other people with infections. And we want to start antibiotic treatment really quickly if a patient has a temperature, because we know that the patient's immune system is not working well during this time. And then the low blood counts are a kind of key feature of this as well, a key thing that we need to think about and perhaps replace. So this is sort of the process, I guess, of how we're trying to manage those side effects during the stem cell transplant. We use called protective isolation, either in the hospital or at home, where patients hopefully in a semi-isolated part of the hospital or in their own home being monitored, perhaps having some blood product support if needed, and then if there's a fever, delivering antibiotics or delivering other medications that help to prevent some of those other side effects. So we use a lot of anti-sickness drugs and drugs that can slow down diarrhea and try and prevent some of those side effects as well. I thought it was useful, a lot of people ask me this when they're coming up to transplant, to think about what that really looks like for a patient. So we often talk to people about needing blood transfusions or platelet transfusions. And actually the vast majority of patients do need at least one or other of those. This was a study that we did in my hospital, looking at the number of red cell transfusions and the number of platelet transfusions. And you can see that actually most people do not need a red blood cell transfusion. 91% had none of those, but most people, about 70% or so, did need at least one transfusion of platelets. And that's because the platelets can often go very low during this time, and we worry about bleeding because they're the cells that help the blood to clot. So this is important information for particularly for patients who might not be happy to have a blood transfusion. So some religions have limitations on that, and so this is something that's important for patients to be aware of going in. There is additional risk if we can't deliver transfusions, because what we're doing is trying to prevent some of the risk associated with having low blood counts. In the longer term, there are some other side effects of the autologous stem cell transplant that I've tried to kind of pictorially present here. So we're going to talk in a few minutes about infertility and effects on fertility and effects on menopause. Also, patients can experience hair loss during the transplant, feel very fatigued, and lose some of the longer term protection against illnesses that might have been developed from vaccinations, for example, given as a child. So we can help with these by delivering more vaccinations. Lots of patients will be revaccinated after a transplant. Hair loss is more tricky for us to prevent or manage without replacement in the form of a wig during the time when the hair is lost, but it will then grow back. But it is a longer term side effect that is important to be aware of. And fatigue as well can also last for quite a long time after transplant. Some people can bounce back very quickly and feel well 2 to 3 months afterwards, but for some people it goes on for longer than that. But one of the things that I think is perhaps less frequently discussed, and because of the nature of myeloma more commonly affecting older patients, is the impact of what we're doing on fertility. And so for this group particularly, I wanted to talk about that. So I think for me, there are two really key impacts of lots of the treatments that we do. So I've mentioned infertility as an impact of melphalan as a chemotherapy. And that can prevent the possibility of becoming pregnant after exposure to melphalan, and that can impact both men and women. And for women, of course, that comes with the associated potential early onset of menopause if that is impacted by the melphalan treatment. That in itself is a really important piece of information to know. And if you're going into that kind of treatment, then thinking about whether your family is complete or whether you need to take steps before having the transplant to enable this to be possible afterwards, for example, by storing sperm or harvesting eggs prior to the transplant, is really important to discuss with your doctor. But I think that perhaps the other thing that we maybe don't we talk about it a lot, but we don't necessarily think about its impact, I think, on younger patients, is what I've described as the kind of impact of family planning. So you might well be aware that we use medications to treat myeloma called immunomodulatory drugs. These were derived from a drug called thalidomide, which was demonstrated to cause harm to the developing fetus. This will only make sense to people in the UK, but there was a very popular television program that ran a story about this issue, and I've included some pictures from that here just to remind people. But essentially what happened was that this drug was used to treat morning sickness a long time ago, 60 years or so ago, and caused an impact on the developing limbs of unborn children. And that has a huge impact on their development and ongoing challenges throughout life. So when we started to use these drugs to treat patients with myeloma, we have therefore obviously needed to follow lots of strict regulations to try and prevent that impact on developing babies from being an issue in patients. And as I mentioned before, the vast majority of myeloma patients are older, so this is probably less of a concern, but still something we carefully counsel patients about. But I think it's important in terms of what that means for family planning. So even if you perhaps have not undergone a melphalan transplant, then the fact that lots of myeloma patients will be taking these drugs in the longer term will obviously have an impact on when a family can be planned as a result of that, because it's really critically important not to either get pregnant or get somebody else pregnant whilst taking these drugs, and really critical to discuss with your doctor how long you have to stop them before that is something that would be safe to do. So I guess I just wanted to highlight that. I think we focus on both those issues as being important in younger patients. So moving on, I wanted to talk a little bit about infections as a side effect. So I've mentioned the risk of infections during the stem cell transplant, which is when essentially the core of immunity in a patient can be damaged by melphalan. But a lot of other treatments can also impact infection risk. And so it's really important to bear this in mind, whatever treatment, part of treatment you might be taking. And also from myeloma itself. So myeloma itself will damage those normal white blood cells from being generated in the bone marrow and therefore increase the risk of infection. So this is a great infographic that Myeloma Patients Europe have put together and is accessible on their website, that looks at why myeloma treatments might reduce immune function. So both looking at reducing normal antibody production as well as reducing those white blood cells, and then potentially damaging some of the natural barriers. For example, if you have bad diarrhea, that can cause a problem with the barrier in the gut and cause an increased risk of infection. Importantly, the different treatments and different other health conditions will impact the infection risk for each individual patient. So it is important to obviously discuss that for specific patient circumstances. In terms of what to look out for, it's again, I'm afraid, just a very long list of anything that can be affected by an infection throughout the body. But this is a great diagram kind of focused in on what patients might experience as a symptom of infection, and then particularly highlighting what we see as the kind of worst situation in an infection called sepsis, which is where the body has a kind of big reaction to the infection that can potentially lead to a very fast heart rate and low blood pressure and feeling very unwell quite quickly. And that's a situation when you'd want to present to a doctor very quickly and get intravenous antibiotics. This is particularly at risk if your neutrophil count is very low. So we describe this as neutropenia. That's one of the white blood cells. If that's particularly low, the risk of developing sepsis can be higher. And usually if you're at risk of developing neutropenia, you'll be advised that if you have a fever, you need to go straight to hospital and receive antibiotics within about an hour, because we know that that makes a difference to people recovering from this severe sepsis. The other things, I guess, are a little bit more practical in terms of what we can do to prevent infection. So I mentioned vaccinations after autologous stem cell transplant, but even if not in that period of treatment, it's important to keep really up to date with any other vaccines that are available to you. These vary a little bit country to country, but the kind of generally recommended ones are listed on the right-hand side of the slide here. So flu every year, COVID is being offered in different countries at very different intervals, but keeping up to date with whatever is being offered to you is important. Shingles now has a vaccine. It's important to not have the live vaccine for shingles. We want a non-live vaccine. Pneumococcal, which is a type of lung infection, has a vaccine, and RSV, which is a virus that can cause lung infections, also has a vaccine. But again, these are not universally available everywhere, so watch out for what is available where you are. They're generally well tolerated. I think most of us have had vaccines. As healthcare professionals, we have lots of COVID vaccines as well. So I know that they make you feel rubbish for a bit, but then hopefully not too long. The other thing, I guess, to think about specific situations would be traveling to different parts of the world. So obviously you would normally get travel advice potentially from your general practitioner, but paying close attention to what vaccines would be safe in a myeloma patients, and this no live vaccines message is really important. The other thing that we do to try and prevent infections is to give lots of tablets alongside any treatment that any haematologist will deliver to treat myeloma. They'll give you a whole collection of other tablets to take alongside it, and lots of these are about preventing infection. So we often use antibiotics to prevent bacterial infections, antiviral drugs to prevent viral infections, and antifungal drugs to prevent fungal infections, often all together. So you often need more than just one of them. We need lots of the different antimicrobials to target all of those different ways of infection. And then that GCSF booster treatment I mentioned at the beginning can boost those neutrophils to try and prevent the neutropenia, leading to an increased risk of infection. In terms of lifestyle actions, I think this is very person by person. I think different people have different approaches to how much they want to change their lifestyle in order to avoid infections. I often say, the only way of avoiding all infections is to never leave your house, which is not what we want people to do, because that doesn't lead to a good quality of life. But there are some sensible things that you can do. So avoiding crowds, especially where you can't move away from people. I work in London, where people are often crowded onto tube trains. They're probably the metro system, the underground trains. They're often the kind of difficult situations where you're really close to people and you can't notice that they're sneezing and move away. And those are the kind of situations to try and avoid. Washing hands, it's easy. Wearing a face mask, perhaps more inconvenient or uncomfortable, but potentially some patients would like to do to try and minimize risk. And then really trying to avoid people who have infections. And I think part of that is about communicating with friends, family, the person who sits next to you at work, as much as you're happy to share information, but letting people know that it's really important you avoid infections. So if they have one, to please avoid you is also really, really helpful. There are specific treatments that lead to a risk of infection that we worry even more about, and that is some of the immune-directed therapies called bispecific antibody therapies or CAR-T therapy. And this is just a long list of approaches that we take to try and minimize risk in those. So some of these we've mentioned already in terms of antibacterial drugs, antiviral drugs, antifungal drugs. And then the other thing on this list is thinking about replacing intravenous immunoglobulin. So I just wanted to kind of explain what that means and think about who benefits from having that replacement therapy with myeloma. So when we talk about intravenous immunoglobulin, we're trying to think about trying to replace the normal antibodies that you might have made because you were vaccinated against specific diseases or exposed to specific diseases earlier in life. And if through your myeloma treatments, those cells that retain the memory of how to react to that infection are destroyed, then you're not able to make those immunoglobulins or antibodies anymore. And so this particularly is a challenge with some of these immunotherapy drugs, because they target some of the long-lived kind of immune memory cells that retain some of that information. And we know that that can be associated with a particularly increased risk of infection. And so there are some things we can do about that. This is a diagram demonstrating that you can replace the immunoglobulins either directly into a vein or subcutaneously, so with an injection just under the skin. And we usually do that, and we try to do that in all patients receiving bispecific antibodies and CAR T-cell therapy. In the UK, that you have to have an immunoglobulin level below 4 to be able to access that treatment, and that is the highest risk group. And that's limited because there is some limitation in the supply of these treatments, but it's really important to get that started as soon as that level does hit that criteria. And first, if you're able to access it before then that is also ideal. These are also used in some other patients. It's not only restricted to patients having bispecific antibodies or CAR T-cell therapy. For example, if a patient experiences lots of infections throughout a year and their IgG level, which is a way of measuring how many normal antibodies there are in a bloodstream, is below the magic number 4, then along with, if the patient's also experiencing lots of infections, then we can use these treatments as well to try and minimize that risk of serious or life-threatening infections. So I've got about halfway and about a third of the way and halfway through the time. So I'm hopefully will spend slightly less time talking about the rest of these topics. But I just wanted to talk about some of the other things that commonly arise and highlight which treatments cause them. So one of those is peripheral neuropathy, which is the words we use to describe damage to the small nerves that help you to feel. So these are long nerves that come all the way from the spinal cord but go all the way down into the hands and the feet and help you to move your hand and to feel what it is you're picking up. And we have the movement fibers, which we call motor fibers, and sensory fibers, which are the feeling fibers. And if those nerves are damaged, that means that you might not be able to feel as well as you could before. So the sensation is lost, it feels numb. Sometimes that can feel like pins and needles. And then if the motor fibers, the movement nerves are damaged, then that can cause weakness in the hands. And it tends to impact the longest nerves. So the longest nerves are those that go all the way down to your feet, and the second longest nerves are the ones that go all the way down to your hands. And that's why the patients experience peripheral neuropathy in the hands and the feet. And it's more common for that to be the feeling nerves than the movement nerves, but both can occur. And the kind of worst offending drugs that cause this are thalidomide, much less so with lenalidomide, the relative of thalidomide, and then a drug called bortezomib, also called Velcade, and then melphalan itself can also do this, that we use in the autologous stem cell transplant. Other things that can cause this kind of symptom are shingles. So if you have a reactivation of the shingles infection, that can cause damage to nerve endings, which can be painful or cause numbness. And then occasionally it can also be caused by the problem that we're actually trying to treat. So sometimes this can be caused by myeloma, very rarely, but more commonly by amyloidosis. And I've tried not to put too many of these horrible graphs in this presentation, but I just wanted to highlight that there are some things that people have done in the myeloma treatment community to try and understand how we could minimize the risk of some of these side effects. And this is one such study which looked at how often the drug called bortezomib is given to patients. And it used to always be given twice a week. And in this very large database of nearly 10,000 patients aged between 18 and 70 at diagnosis, they looked at patients who'd had once weekly dosing and those who'd had twice weekly dosing. And they looked both at the rates of peripheral neuropathy, which were higher in patients who had this drug twice a week than once a week. And then really importantly, these curves look at the outcome for patients on those treatments. And you can see a blue line and an orange line. And the fact that they exactly lie over the top of each other means that patients had exactly the same outcome in terms of duration of remission, but also in terms of overall survival, whether they had once weekly or twice weekly treatments. And so by doing this kind of study, the authors have shared with us that it doesn't matter from a myeloma point of view to have bortezomib only once weekly rather than 2 weekly, and it will reduce the rate of peripheral neuropathy for patients. And so that's what most doctors now prescribe, weekly dosing of bortezomib rather than twice weekly dosing. In terms of what to do if this does occur, we have the best thing to do is to try to prevent it from getting worse. So the first thing is, if the symptom starts, to try and stop the drug that's causing it and then wait for it to improve and then go back in with a lower dose of the drug to try and get a dose that is doing good things to get rid of myeloma but not causing the same degree of side effects. And then there are some other approaches if it becomes painful. So gabapentin, pregabalin, and duloxetine are tablet treatments for pain, specifically good for nerve pain. Some people find lidocaine patches can be helpful. These are like a local anesthetic kind of treatment patch. Menthol cream can be helpful because it just sort of distracts the nerve from feeling painful. And then some patients report that acupuncture can be helpful for peripheral neuropathy as well. So I'm sort of moving a little bit around the body, but we're going now to the heart and the lungs because I thought we should just talk a little bit about these kind of critical organs. These are rarely affected by myeloma drugs in reality. So most patients will not experience a side effect that affects their heart or their lungs. The one thing we watch out for, particularly with the immunomodulatory drugs, is the risk of blood clots. So that the risk of blood clots can be increased with just having myeloma, and then these drugs particularly can increase that risk too, and that can present with a sore or swollen leg or feeling shortness of breath if that clot has traveled to a lung. And so if those symptoms are noticed, then we need to do some tests to look and see if there's a blood clot. And we also give drugs alongside these immunomodulatory drugs to try and lower the risk of blood clots. So blood thinning drugs, often drugs called DOACs or apixaban, rivaroxaban, those sorts of drugs, but sometimes aspirin or other blood thinning drugs. Effects on heart pumping are fortunately very rare. So in terms of direct impact on the heart, this is very unusual. This has been seen with a drug called carfilzomib. There was a slightly higher rate of effects on heart pumping in studies where half of the patients got carfilzomib compared to the other half who didn't, but it is still very rare, sort of less than 3 in every 100-ish, if I remember rightly from the top of my head, in that study experienced that to any significant effect. I've already mentioned kind of upset tummies from the autologous stem cell transplant process, but some of the other drugs can cause those side effects as well. Thalidomide particularly causes constipation, and then ixazomib and selinexor are drugs that are kind of more commonly than others cause nausea. And there are some ways that we are learning how to manage this in terms of specific drugs that can be helpful. So we use anti-sickness drugs, but another drug called olanzapine is thought to be helpful specifically for the nausea that comes with selinexor. And then the picture at the bottom is just because everybody likes a picture of what we call the Bristol stool chart, which measures how watery or otherwise your bowel motions are, with diarrhea being at the top. And this is from a study that we did in the UK, looking at the drug called lenalidomide and how that affects how that can cause diarrhea in some patients. And we did a study trying to understand why that was and why patients were getting diarrhea, and identified that it was as a result of something called bile acid malabsorption, which can be improved by taking another drug called colesevelam. So only by doing these investigations to really understand why a drug causes a side effect, can we then do something or understand what it is we could do to try and help it. Eye-related side effects of drugs is kind of topical because there is a new drug treatment for myeloma that can cause some eye-related side effects. But actually, several of the drugs that we use to treat myeloma can cause an impact on the eye. And this is a problem called blepharitis, which is essentially inflammation along the edge of the eyelid, which when it's not very bad looks a bit like this, and when it is very bad looks very sore. This can be associated with using the drug called bortezomib and potentially some of the other drugs that are similar to this. But it's quite difficult to quantify because it's sort of bothersome, but it doesn't always need antibiotics, or it doesn't need antibiotics, and so it's not always well picked up. And basically, it just requires you to try and keep the pores open, so the pores at the under the eyelashes open to allow the flow of normal oils out of the eyelid. And so there are some ways of doing that with warm flannels and kind of gentle massage with your eye closed over the top of the eyelid. But sometimes that can result in needing to reduce the dose of that drug. I guess the other common eye side effect we see is cataracts, which are where the lens of the eye can become less clear. And this can be associated with steroids, which thankfully we're trying to use a bit less in the treatment of myeloma, but are still very commonly used in lots of drug combinations. And so this is something that can easily be fixed by replacing the lens in the eye with a new lens through a cataract operation, but is something to watch out for. And then this is the drug belantamab mafodotin that's recently been approved that also causes a very different kind of eye side effect, so not the eyelid problem or the lens problem, but it can cause some changes to the very outer surface of the eye, the surface of the eye where you would, for example, put a contact lens, that kind of portion at the front of the cornea. And it's really important if you're taking this drug that your eyes are assessed before each of the first 4 doses to monitor for this side effect. And then we have some guidance as hematologists, as to how to manage this side effect in terms of holding dosing of the treatment and then restarting. I think I've talked quite a lot about holding doses or reducing doses, and I think patients often find that difficult because there's a worry that by doing that will affect the successful treatment of myeloma. But I think we're not usually stopping it completely. We're usually stopping it, waiting for something to get a bit better, and then adjusting the dose to try and ensure that we can carry on with dosing to ensure that the kind of efficacy of the drug is still there. So I wouldn't be too worried about that. If you need to hold a drug for a short period of time to get over a toxicity, that's fine. And we can then start in a way that's hopefully more tolerable. I wanted to briefly mention the reactions to some of the newer drugs. So we use all of these are different kinds of immunotherapy treatments, and sometimes when they're first started, they can cause a bit of a reaction. And therefore, often you'll be asked to be observed in hospital either for a few hours during the day or perhaps for overnight or a few nights in the case of bispecific antibodies, or for a week or a few weeks in the case of CAR T-cell therapy. These are often symptoms like fevers and feeling chills or sweating, but can sometimes be small things like localized skin reactions, but that can be quite bothersome at the site where the injection goes in. The kind of more severe end of the spectrum is this side effect called cytokine release syndrome, which is where with these immunotherapies, particularly bispecific antibodies and CAR T-cell therapies, we're really trying to activate the immune system to target the myeloma cell. But if we overactivate it, then that can cause symptoms like fever and low blood pressure. And so that needs to be calmed down a little bit, which is often why patients will need to be in hospital to start these treatments, or close to a hospital to be able to return very quickly. But we can manage them well, and we have simple drugs like paracetamol or intravenous fluids, but also a drug called tocilizumab, which calms down the reaction and that helps that recover. This is, unlike all the things I've mentioned, this is rare in that it doesn't occur in everybody at a significant rate. It does occur quite commonly with the CAR T-cell therapies, which are listed here, but the rates are much lower with bispecific antibody therapies. And grade 1 or 2 is less severe than a grade 3, so the severe reactions are occurring much less commonly and much lower frequency with the bispecific antibody therapies compared to CAR T-cell therapies. ICANS is the kind of end result of CRS. If we don't manage to control it and keep it under control, all of that fever and inflammation can affect the brain, and that's what we're trying to avoid. And again, this is more common with CAR Ts than with any other treatment, but severe end of the spectrum again is still very low in only 3 out of 100 or so patients. My last organ system of the body that we haven't covered yet is skin and nails. And this is a side effect that's caused by one very specific approved drug, which is called talquetamab. But this side effect is an impact of targeting this protein called GPRC5D, which is what talquetamab targets. There are other drugs that also target that, as and when they're developed, would also be expected to cause these side effects. And in the trial that looked at this drug, patients reported noticing that they had a change in taste and therefore ate less. They reported experiencing dry mouth or difficulty swallowing because of the dryness. And that was seen quite commonly. We're learning a little bit more now how to manage these symptoms. So I think in the more recent trials, this was the first trial, hence TAL1, of this drug. And I think we're learning a bit more how to manage that. And then apart from effects in the mouth, this drug can also affect the skin in terms of skin peeling and nails. Nail impacts, which again are not dangerous side effects, but can be really bothersome, and so are important to kind of mention when you're being reviewed, and think about how we can help to manage that, either with creams or with other approaches to help. These often get better after a few months, so they tend to happen when you start talquetamab, but then go away and get better after that. So I think I've covered every possible part of the body, hopefully. I can't think of too many other parts of the body to talk about. And so I just wanted to end with a few thoughts, because people often ask me how we report side effects that patients report in a clinical trial. So obviously when I see a patient in clinic, they tell me what they're experiencing, and we think about that in their specific context and how we can help to manage that. In a clinical trial, we're trying to do that in a very numerical way. We want to try and capture in a way that we can report over perhaps 100 or 200 patients what the rate or proportion of patients experiencing a side effect is. And mostly that's done by a doctor who sees the patient, assessing that side effect and then assigning it a grade, which I've mentioned as we've gone along. But it's perhaps more of a move towards also trying to move away only from a doctor-assessed side effect to something called a patient-reported outcome. So using the patient's report of the symptom, which perhaps can sometimes be subtly different to the number or grading that the doctor who's seeing them will write down. And importantly, this has to be done in a very structured way if you're going to do it across a whole clinical trial. And so there are a few scoring systems that can be used to do this, and we're seeing these being used more and more in clinical trials. These are assessments of both quality of life, but also specific symptom scores for potentially for specific side effects. So in trials that use the talquetamab drug that can affect taste, we have specific scoring systems to ask patients about their experience of taste change, for example. And so more and more we're hopefully seeing reports of these in studies coming through, and you can see that different ones of them are used variably in different studies, but we're seeing that being more widely reported. So I'm going to stop there with what I hope is not too overwhelming a long list of potential side effects, with the reiteration that most of these side effects, most patients will not experience most of these side effects at any point in their myeloma treatment, and they're things to be aware of and report and look out for, but not to worry about, and not to think that everyone will experience at some point.